today. I don't have anything to disclose. So traditionally, Blakemore tubes have been used for the control of acute upper GI bleeding. However, as more advanced endoscopic technologies have come about to control bleeding, the availability and familiarity with Blakemore tubes has decreased among hospitals and staff. So moving forward in these emergent situations of upper GI hemorrhage, if we're moving away from Blakemore tubes, there needs to be other options. Our institution does have experience using aortic occlusion balloons to occlude the GI tract for endoluminal endoscopic surgery, and this was kind of what sparked this idea moving forward. So I will talk about two separate patients that came in with acute esophageal bleeding that was ultimately controlled with the off-label use of an aortic occlusion balloon. The first patient is a 44-year-old female who came in as a transfer. She had a prior thoracic aortic aneurysm repair. She came in with hematemesis. She ultimately became unstable and required blood products and pressor requirements. She was taken for an EGD with GI, which showed esophageal bleeding concerning for an aortoesophageal fistula. She was initially taken to the operating room by vascular surgery, which placed another aortic graft. They performed an angiogram, which did not show any extravasation, but unfortunately in the OR, she still had large volume hematemesis. So at this point, there was an emergent intraoperative consult to MIS. So we put a scope down, and about 28 centimeters, as you can see here, there was a lesion with a large amount of pulsatile bleeding going on. We were in a hybrid room, and we initially tried to inject epinephrine to no avail. So there was no Blakemore tube available, and so we thought back to our preclinical experience using these occlusion balloons in the GI tract and thought that this may be a good solution here. We did recognize that it was an off-label use for the aortic occlusion balloons, but this patient had life-threatening exsanguination, and we felt like that the risks were worth the rewards. So in a second here, you're going to see the aortic occlusion balloon be passed down in parallel to the scope. We took it down to the site of bleeding and then inflated the balloon. Pressure was held for about 10 minutes before the balloon was deflated. And then you'll be able to see that we actually had pretty good hemostasis at this point, which allowed us to have more time to put an over-the-scope clip and perform more definitive hemostasis. The next patient is a 75-year-old male who has a history of gastric cancer. He underwent a total gastrectomy with esophagojejunostomy. Unfortunately, soon afterwards, he had a leak at his anastomosis, which was managed with an endoluminal vac and ultimately a stent. He was discharged home and then came back shortly after with hematemesis. He was taken for an EGD, which showed almost complete disruption of his EJ anastomosis. So this was initially managed with an endoluminal vac. Unfortunately, soon after being placed back in the ICU, he had pulled his endoluminal vac tubing and had large volume hematemesis. So we took him emergently to the OR and performed an EGD, and you can see all of this bleeding. This is all the tissue down towards the disrupted anastomosis. It was all friable, just a large amount of bleeding. And this is another scenario where we thought the aortic occlusion balloon would do well. So again, it was passed down in parallel to the site of bleeding. It was inflated and pressure was held for quite some time. And then the balloon was deflated and we had pretty good hemostasis. So there's a balloon still inflated and now it's deflated. This time we were, and you can see the suture from the failed anastomosis. We did use 3 separate through the scope clips to provide definitive hemostasis in this situation. So these two patients are good examples that aortic occlusion balloons can be used for the control of acute upper GI hemorrhage, although it is an off-label use. They're especially a good tool to temporize the bleeding until you can use more definitive endoscopic means to control the bleeding, such as the clips that you saw in these two patients. Thank you.